Can you hear me now?
I can, yes.
Too many windows pulled up. Yeah, I can share. That's easy.
Thank you.
I missed the first few minutes. Did we say people are not
So
available today? I'm sorry.
Eileen was saying it's going to be light attendance because of some competing things.
Oh, okay.
So I just said that maybe we could come back a second time and she's going to reach out to Laura to see if there's an opportunity to do that. Because
Got it.
you have good news and I just always give reminders.
Yeah. All right. Can you guys see my screen okay? I don't like this mode though. How do I get out of this mode?
Yeah, switch to
Slide show.
How about now?
The button up top that says slideshow. Keep going over to the right. So there's
I think it's probably showing the wrong screen because it's on one screen but not the other.
we're seeing your screen.
so go all the way to the bottom. Now can you have a switch displays? Yeah,
There you go.
Perfect.
Perfect. Thank you.
Mhm.
So thank you both thanks everybody for having us today. I'm just going to go through some key reminders for clinical operations. And we always put these slides in there's a Teams channel, I believe. That's where Joyce had asked me to do it. So we'll put them in there. But the one thing that I didn't include on here is that I'm gonna make a sweep of all the exam rooms to see what's in the pockets again, to make sure that everybody has what they need in the exam rooms as far as specimen collections, tips on annual wellness visits, tips on hypertension, tips on hospital follow-up visits, et cetera, et cetera. So if there's anything that you would like to see in those pockets, please let me know. And then, so for vaccine and medication administration, across the hospital, I think in ambulatory, just in the last month, there were over 100 medication errors, and something that we are being sticklers about, and rightly so for patient safety, is that the MAs or the nurses must document medications at the time of administration. So when they're giving a vaccine or an or an injection, they will have to be in the computer at that time documenting in Epic. So you can have them do these before your visit or after your visit, or they're just going to have to interrupt your visit because they have to scan the medication and document at the time of giving administration. For rooming patients, just again, allow adequate time for the patient's rooming to ensure preparation. We ask the MAs to look at the storyboard for the care gaps. If there's an annual wellness visit, they have to do the HRA. There are about 16 steps to rooming: medications, vital signs, chaperone questions, the GAD, the PHQ-2, the alcohol substance use disorder screening, allergies, falls. So there's and then the vitals. So there's a lot that goes into rooming. And if an exam room is not available and or the provider is running behind, the CMA will have the patient wait in the waiting area for the provider to then greet them. So they may have roomed your patient, but because you're running behind or it's too early to see the patient and you can't see them early, they're going to have the patients wait back in the waiting room. Team communication is really key. So use of secure chat for assistance if CMAs are not visible at the workstation. Once you put an order in, the button turns blue so they know that there is an injection or an immunization to be given or a specimen to collect. And you can secure chat, but the blue dot, once the order is in, that happens automatically. if use of secure chat also to communicate when you're running behind with or your ability to see patients earlier than scheduled. So we're really trying to make our waiting room safer. We don't want patients to get upset when the provider is running behind. So we're letting patients know the provider is running behind, but we will make sure that you get all the time that you need to be with your provider. Your time will not be cut short. But it's very helpful if we communicate via secure chat if you're running behind. Same thing. If you want to see a patient early, just communicate that via secure chat. So I'm just going to stop there for a minute and see if there's any questions or any comments or any concerns. And then I always encourage on both, we're all a team. So for all members of the team, so for the providers to check in with the CMAs and for the CMAs to check in with the provider at the beginning of the session to communicate anticipated patient needs, clinic needs. Like, you could let them know, I'm probably going to do these vaccines for this patient today. I see that this person's in for an annual wellness visit. I don't know if I'm going to be able to do that today. I understand that this patient has hypertension. You might have to take their blood pressure a few times. We might have to do the Omron. So just that kind of communication back and forth, I think, is really important. And then the last thing is that we are in the Joint Commission window. So they can come probably anytime between now and the end of the calendar year. The thought is that they are probably coming soon. So I would think in the next month, it could be the next week. It will be a 4-day survey. They will definitely come to ambulatory. They like to do what's called a tracer, where maybe one of our patients was seen in the emergency room, and then they might say, oh, I want to go to the clinic where this patient is seen. I want to look at the note that the last provider wrote. I want to look at the last visit for when they were here in the clinic. I want to go to that clinic. So those are some things just to know that they're going to come here probably to this clinic. If you see anything in the environment that is unsafe, or you see, I don't know, there's a rip in the chair, or the pain isn't good in your exam room, please let Abby or I know that. We've been doing more frequent environmental rounds, but things happen and we need to know about that. Please make sure you've removed your personal belongings from your exam rooms every day. And make sure that no confidential information is left in an exam room. So that's my little spiel on the Joint Commission. There is an Epic upgrade coming on March the 20th, 2025. One of our nurses will be sending out an email about that. There's, hundreds of pages of the Epic upgrade, and I think it's just important that we know as staff and providers in clinic what will impact us. And then the ID intranet, this was a suggestion from our ID intranet retreat, is now on the bottom of the e-huddle every day, the link to that. So that's a really good place for you to go to look at resources. And those are some of my reminders for this month, and thank you for listening. Anybody have any questions, comments, concerns?
Sheila, can you just briefly mention, like, what are the things that we are most likely to mess up on the Joint Commission? Like, hearing that just makes me feel non-specifically nervous, but I'm just like, what are the things that, like, obviously eating and drinking, got like that, not okay, but other things we should be mindful of?
That you're not leaving a screen up and walking out of your exam room. They're going to look to see, this is more CMA, but the chaperone questions, if somebody said they wanted a chaperone, that you have a chaperone in the room with you. They might say to you, provider, what do you do in case of a fire? And you're going to say, I'm going to find the closest fire alarm and we're going to get out of here. Make sure that everybody's safe. They might ask you questions about if you're seeing a patient that you think has a PUI, what kind of PPE are you wearing? They might ask you about, you know, what do you wipe off the blood pressure cuff with? What do you wipe off the otoscope? Well, the otoscope, you change the little tips on them, but what do you know, those kind of things, disinfection. They'll probably ask CMAs more of those questions. For GYN, they might ask you, and I might ask the GYN providers, what happens with the dirty instruments? And we spray them with the pre-cleanse, and then we take them over central sterile to be sterilized. Trying to think of what else they might ask you. Stephanie, anything else you can think of?
Not off the top of my head, but we do have a checklist that can be sent
Yep.
out. And then also the biggest thing is if they ask you something and you don't know the answer, just say, I'm gonna find someone that may know the answer. You don't want to give the wrong answer. So if you don't know, it's okay to say, oh, I don't know, but I know where to find that information.
And then the other thing is, you know, answer their question. Don't go into a lot of other things. Just keep it simple.
Great, thank you. Any other
Yep.
questions?
Thank you for your attention. I appreciate it. So Stephanie's going to get into our quality metrics, which
Ye-
we had an amazing year. So thanks, everybody.
Yeah, so I thought it was really important for us. I think the last time we met, we talked maybe in October, but I thought it was really important for me to share with you all our outstanding end of the year performance. We've been receiving lots of kudos and accolades for how well we've done. And I think you guys should all know because I do appreciate your commitment to excellence and we've made major achievements. And so I'm really proud of the work that we've accomplished together. So I'm going to just share our December dashboard. We had, this is our primary care quality metrics. Give me 1 second, let me move this so I can see my screen. These are our primary care quality metrics. So as you can see here, we had lots of stars, lots of blues. Out of all of the 8 core measures, 7 of them we improved from 2023 compared to this year. We were meeting for depression screening, HbA1c control, statin therapy in diabetic patients without cardiovascular disease. We were at target. Our well visits for our young population, we only had the 1, but we were able to get that done this year. And our well visits for 65 plus, we were at 77%, not too far from meeting the target. And then everything has improved from year to year, from last year to this year. So thank you guys so much for that. And then these are our diabetes care end of the year performance measures. So these are our patients who are diabetic. They're looking at how we control their blood pressure. And as you can see, we were at target there. Their kidney health, we're managing that with the microalbumin and CMP levels, EGFR levels. We were at target for that. And I know that was something that I've talked about throughout the year, trying to get patients to get those microalbumin tests done. So thank you so much for that. And even the diabetic eye exam, we were only less than 3% away from target for meeting that. So people are getting their diabetic eye exams done. And so we're making those referrals. And we also have the same day workflow that we're trying to really implement and get off the ground for patients who just haven't been able to get to Wilma for their eye exams. And then these are our end of the year performance dashboard for pay for performance. So 5 measures at target in December, and 2 metrics outperforming December of 2023. So lots of blue. Thank you so much for that. And then this is our value dashboard. So our value dashboard is showing the improvements that we've made with hospital follow-up, phone calls, hospital transition to care management appointments, and also our readmission rates. I couldn't find the dashboard has expired out, so I couldn't find the comparison from last year, but we did increase, we improved in each measure from last year to this year. And then we have a wonderful nurse, Fatima, who is working to call patients to get them in here. She's calling them 2 days after they've been discharged from the hospital, calling them within 7 days after they've been in the emergency room. And then the goal is to get them in here for an appointment. Sometimes we do schedule the appointments and the patients don't come in. or sometimes we're just not able to reach the patients, but she is making significant efforts and the metrics do reflect that. And also our 30-day readmission rate has gotten better from last year. And I just wanted to briefly go over some changes that's coming. So the kidney health evaluation measure is going to now move from the diabetic registry to a core measure. So it's going to be a core measure. And then there were several metrics that they adjusted the target. So it might be just a bit higher target and difficult for us to reach. So colon cancer screening, that measure is going to increase from a target of 75 to 76. Then we have hypertension, controlling hypertension. So these are our patients with blood pressures 140/90 or greater who really should come back in for some type of follow-up. It could be a RN follow-up, physician follow-up, PharmD follow-up, to control their blood pressure. That measure is going to go up from 77.83 to 79. And then we also have the kidney health measure, which is going to increase from 59 to 65%. I have no doubt in my mind that we can achieve our targets the same way that we did this year. But I just want you guys to know that those were going up. And then the last slide, what happened to my slide? Just some continued best practices for quality initiatives. So number one, we talked about this at the last meeting. The nurses are having administrative time to dedicate to outreaching patients, following up with them about their blood pressure, about their mammograms, colon cancer screenings, any barriers they have, coordinating care. So we're going to continue with targeted outreach efforts, and those nurses having dedicated time to do so. Care team meetings, if you are not already having care team meetings with your nurse, a lot of providers and nurses are doing it, and it goes great. That's an opportunity for you to really talk about your complex patients and that are coming in for clinic, or maybe you've just seen them and they have several issues going on that you want to kind of address. So if you're not doing those, I do suggest starting to do those because those are really helpful. Same day workflows, I want us to be able to continue to optimize our same day workflows this year. So our mammogram patients who are just overdue and we just cannot get them to make that appointment once they leave the clinic. If they're here for a same day visit, we can ask them, hey, are you willing to go over to JHOC and get a same day mammogram done today? And this also includes our priority partners patients. They are able to go over there as long as it's screening only. They can't do a diagnostic. And as I was talking about earlier, we do have the diabetic retinopathy screening option at JHOC. In internal medicine, they have an IDX machine. So for our diabetic patients who, again, just have not made it to Wilma for whatever reason, if they're able and they're willing, they can go over to JHOC to have the diabetic retinopathy screening done. And at least that's, something that we can kind of knock off the list for them. As far as blood pressure management, I've been encouraging providers, if you're seeing your patient, the workflow is that if their blood pressure is higher than 140/90, they're supposed to have a second check. It can be an arm run check, or if you are a provider that likes to check your own patient's blood pressure manually, that is fine as well. But if they're leaving out the door with blood pressure that's still elevated, they have to have some type of follow-up. And we have blood pressure cuffs that we can give them. If we're giving a patient a blood pressure cuff, there should be some follow-up. So please let your nurse know, hey, I gave Mr. So-and-so a blood pressure cuff. Can you please give him a call and follow up with his readings in a week, 2 weeks, 3 weeks? And if there's more targeted interventions like medication management, or maybe they need education about diet or things of that nature, please let us know. The key is they can't leave out of here and not have an appointment for 3, 4, 5 months. When I do chart reviews, I do see a lot of patients who leave here with really elevated blood pressures and they don't have a follow-up schedule. So we want to get them back in so that we can control their blood pressure as best as possible. Wellness visits, they're going well. Please continue to do them when you can, when they're scheduled. If there's a patient that comes in and there's just too much going on, or maybe they're running late or too complex, that is okay. We understand. Please just put in your wrap-up note, reschedule patient for annual wellness visit. If you need 60 minutes with the patient because of their complexity, please indicate that in your note. And then the last thing that we're asking is for those wellness visits that you actually do complete, you can put in your wrap-up note for them to be scheduled for a year out for their next wellness visit. In terms of transitions of care improvement, last year we talked about a clinic pilot. We haven't been able to utilize it as much as we wanted to, but with this pilot, patients who are discharged from a hospital admission who are high utilizers or have a high risk for readmission, they can see you as a provider, but also they can see Kristen Kilcrease, our pharmacist, for a more extensive med rec. I have heard from providers that sometimes these patients, when they go into the hospital and come out, they have lots of medication changes, and it would be helpful to have the med reconciliation done. So Kristen is a resource for that. So please just let us know if that's not happening, or if you feel like there's a patient that you saw that can benefit from a more intensive med reconciliation. And there's continued conversation with Sheila and myself, Fatima, about improving our transition of care workflow, maybe redefining that workflow. So more to come on that. And in terms of our colorectal cancer screening, I just want to remind you all that Nina is here as a support, but she has taken on a new role. So your continuity RN can also help our patients with colon cancer screenings. We have navigation support as long as they know at least 2 weeks in advance. You can secure chat Siobhan, and we can, the patient needs an escort because they're going to anesthesia. We can coordinate that with the navigators. In terms of bowel prep education, a lot of our patients may not understand what to do or how to do it. That's what you have a nurse for. Let your nurse know. And we also have a par of clear liquids in the clinic for people who need them, for patients who can't afford to go out and buy the Gatorades and the Jellos. We have a stock in the office, and so they can access that if they need it. And in terms of your patients who are going to do the Cologuard, we have 2 demo kits in the clinic that can be used for education. So just let your nurse know if your patient is saying, hey, I don't know what to do with this. It is it's simple for us, but it's difficult for patients to understand what to do with that because there's lots of steps and lots of parts. So just let us know. And again, I just want to thank you so much for all your efforts. It's evident and reflected in how well we're doing. And I know that we can continue to do great things in 2025. And I'm here to support you guys if you need it. Thank you very much. Any questions?
Thank you so much, Stephanie, for all the work you do. David, do you have a question?
Yeah, Stephanie, you mentioned for patients with high blood pressure, tell your nurse. What do you think the most efficient way is? Is it having them schedule a nurse visit in our checkout note? Is it a secure chat? Is it staff message? Is it verbal? Just so that that message gets across and is able to be followed up on.
So if you're seeing a patient or talking to a patient over the phone, I would say have them scheduled for a nurse visit, but just let your nurse know, because sometimes we have other things, right? You don't want to schedule a patient with on at 12 noon if he's not here. So just let them know as well. It's helpful for me when like I'm covering a few doctors right now. They'll just tell me and I'll call the patient and get them scheduled myself. So either or, but definitely communicate with Leon so we can make sure that we're present when the patient is coming in.
Yeah, I think it would be secure chat I agree with Stephanie, secure chat your nurse. And, the nurse should be able to get back to you and say, yep, let's schedule them for an RN visit.
And then I just wanted to also underline that point about the discharge med reconciliation. So I had a patient who was admitted for a cardiac event and got an intensified statin, was followed in pillboxes support through the clinic, but was discharged with just the new higher dose of the statin, as they were like, continue taking these meds, and like they do on the discharge summary. But so then that person went home and would have gotten like 1.5 times the statin dose they were supposed to get, because they had a new bottle, but also had loaded into their pillboxes the old dose of the statin. And so I wonder if there's some specific workflow we can have for people who are already in pillbox support, because a lot of them have like really, and maybe Siobhan can comment on this, but like have complex regimens. And, there's just like, because if they don't bring the pillbox to the appointment, then it's very complicated to say, don't take the pink one.
Yeah.
That's hard.
I think so were you able to see the patient after their discharge?
So this person actually was picking up their pillboxes on the same day. There was some period of time where they may have been taking twice, like in between. But then I just went through and pulled it all out and put in the new one, because I had the benefit of being in the office with the patient, getting those 2 things at the same time.
Yeah.
But that's like an unusual event, right?
Yeah. Can you actually, when you get a moment, doesn't have to be now, send me who that patient was? Because that's actually like a safety issue. We really do want to kind of prevent that. I know when I do transition to care management, when I do my chart review, I kind of can look through, and if I see that it's a patient that's meeting with Siobhan, I will loop Siobhan in and let her know, like, hey, this patient was discharged with the medication changes, so that she knows that the changes need to be made when they come in for that next pill box. So we probably need to figure out a way to fine tune that.
Yeah, and it like we used to do in the inpatient side, we used to have support to do pill boxes for people being discharged. We no longer do. But like recently I was the attending on and had a patient coming back to Bartlett. And so I did one for her and like for 2 weeks before her follow-up and then told her to bring it. But I just think that transition is so hard. And this was someone who was not taking any medications at all and was going out on 5 different pills with different end dates for a couple of them and switch, like it really, really complicated, did not feel at all fair.
Yeah.
Or did not feel like a recipe for success.
I
Mhm.
think that's a definitely talk to your nurse about that when that person's going to be discharged.
Yeah, I mean, this wasn't my patient, right? Like it's not my outpatient. I was the attending inpatient.
Oh, okay.
But
Right.
were
So-
they a Bartlett patient?
Mhm.
So, but I
So-
still think that I think, if you know who the provider is, you can always reach out to the all Bartlett, all RN, group or me, and I'll be like, okay, I will have this nurse follow up if you're getting ready to discharge a patient. That is really like, they don't know an inpatient who has pill boxes versus who doesn't.
Right.
And we've had this
No.
happen a few times. Like I went and saw a patient. I went on my way home one night because he had no clue what was going on with his pills, right?
Right.
And
Yeah,
Dr. Bissett and I packed 2 boxes, and I just said to him, throw everything else away. These are the boxes that you're supposed to use. And I hope that he did, and I think that he did. But that's a big, I mean, it's a big problem with a lot of our folks. Yeah.
I can tell you in my experience, yeah, I mean, it's a major problem when they're discharged from anywhere, and
Yeah.
particularly these long-term care facilities are even worse.
Mhm.
But what I've tried to do is work, and Stephanie, thank you for mentioning that, work well with, because I work remote, a couple of days a week and everything. If I'm at work, it's not a problem. But when I see that someone's going to be discharged as well, I try and contact the patient, see if they could bring those pill boxes in, or definitely don't use the pill boxes that they have at home, or if the pills are really pretty easy to distinguish. So what I try and do is try and work with whoever's on site to try and help with that. I do have some providers that will send me a message when they're going to make a change or whatever. And this isn't necessarily that they were an inpatient or anything, that will let me know. They'll say, oh, it can wait till next pill box fill, or it needs to be done. Then obviously if I'm there, I can do it, or try and work with the nurse that's with them, or even the pharmacy itself to see if they can help. And one of the things for my patients, I've been able to put in the description in the encounter pillbox fill. So that would maybe alert someone to look at that, because that says what's in the pill boxes and all. It's a real problem, and I can only imagine for the people that we're not doing pill boxes for, that it's even worse, because they just go home and have all these different bottles and they're taking it all, and try and instruct patients always bringing all those pill boxes from home. I want to see, particularly after they've been discharged from somewhere, I need to look at them all. And so anyway, it definitely is a team effort for all that.
And that is one of the most important reasons why a good transition of care management is important. It's beyond just calling the patient and checking off some boxes. Patients really do need to be seen. And we kind of need to figure out what's happened to them while they were in the hospital and what the follow-ups are after they leave, medications, specialty appointments, and things of that nature. So if you have any, Dr. Scully, send me that patient when you get a chance. I just want to look at it, because if that's happening to that one patient, I can just imagine it is happening to other patients. And I'm always thinking about ways that we can improve our practices.
Yeah, no, and I mean, honestly, I think like Bartlett, we do better than a lot of the other clinics because we at least have the closeness of connection. But on the inpatient side, it does often feel like we do a lot of work that may not carry over into long-term success, even when there's people who are ready and willing to engage. Because, you know, this one I'm thinking of recently, I mean, she, you know, she was supposed to stop the fluconazole on this day, switch from treatment dose to prophylactic dose Bactrim on this day, you know, do like lots of just little changes that are easy to mess up in a pretty straightforward case of just AIDS, PJP, and Candida esophagitis. Like, this is not super complex. This is just straightforward.
Yeah. The other thing that I think that we should
with the home
Stephanie,
nursing, if they have home nursing, I've dealt with the home nurses as well, which is good because what I do with patients too, I give them my phone number, and often I'll get a call from even a home health nurse or something to say, oh, I'm with so-and-so. So looping them in as much as you can, or making sure people have your phone number and things. I'm sorry, Sheila, I didn't mean to cut you off.
no, it's fine. I just think, Steph, when we, with Fatima, who does most of these, or just telling all the nurses, like when you're calling patients for the hospital and even the ER, transition care management, I think one of the questions is, did you have med changes, right?
Yeah.
So I think we need to be really on top of, if they say, yes, we had med changes, that we say to the person, do you understand what they are? Do you have pill boxes there that, you know, you're not supposed to be taking this hydrochlorothiazide anymore? Do you know what that hydrochlorothiazide is? And if they're like, no, then I think it's I think it's up to the nurse to be saying, okay, I need you to come in and I need you to bring all your pills. So I think we need to do as good a job as we can, that, you know, we can't depend on the inpatients to do, like, they're not going to do it. They are just not going to set these people up for success. Eileen, you doing the pill box was probably like, that's wonderful, above and beyond, but that is not going to happen.
Sheila, there is an expectation that we could raise for the inpatient side. I mean,
Yes.
sometimes I get a note that my patient's admitted by the residents, and sometimes I don't. Sometimes I go, I see the patient, I talk to the team. Hey, when they're going home, please let me know because we'll coordinate. And then, like, you know, either the teams change or it's just busy, and then you don't hear that follow up. So
yeah,
I don't know. I'm sure there's some protocol that's just amongst all the other things that the Polk residents are trying to do. It's hard to let the outpatient team know, but it would be so helpful just to get a secure chat. Hey, so and so's going home today, and then we could help. I don't know if that's unrealistic, but for those of you who do,
it's something to strive towards,
I
right?
mean, it was the standard when I came here, right? Like, that was the standard of how Polk patients were cared for, because there was a nurse manager on the ward.
Michelle would do that.
Right.
She fill boxes. The other thing is, I normally know if it's someone that's been hospitalized.
Who would do this? Hold on a minute.
Michelle, she was a nurse that was there years and years ago.
Back on the Polk unit.
But not that many. I mean, like, I've only been here for 8 years, and there was a nurse in that role for the first 2 years I was here. It was Deb Michelle for the first year, maybe 2 years. But I think what has happened is the hospital wants the nurse care coordinators to be modular so that they can be moved around to anywhere that needs assistance. So they have moved away from having like a dedicated nurse in that role for a service. And I personally, like, I think that, like, urology nurses know about things that urology patients need, and HIV, that there is a role for that, but that probably isn't the most widget-based approach to inpatient management. There is, however, a person who helps the residents with care coordination, who I think is entirely virtual, but who I think I could talk with Joel about trying to, like, work to set up a little bit better communication, at least for our Bartlett patients.
So here's the other thing. You know, we just hired a new pharmacist that's going to do pill boxes. And one of the things that she did in a previous job was work with inpatients. Do you understand? So that the whole from inpatient to outpatient. Because when I interviewed her, I was like, oh, this is great. This is kind of, we need this. So I think, I think it is something that we can go towards, that Amina is her name, that
Mhm.
again, that there is a secure chat. This Bartlett patient is going home today. Amina, can you come up and please go over meds with this person? Right?
Yeah.
I
And I
think
think
that could totally happen. And I think it's something that's so important because many of our patients just don't have that health literacy. And just to, like with that guy I was telling you about, I said, throw everything else away.
right.
Right? Because
Right.
nobody's gonna take it back. Like what we no need to keep it, right? So throw it away. These are the pills you need to take.
And every attending who takes care of patients on the public service gets a standard email from Joel with resources and things to do and expectations. And so every 2 weeks or every week, whatever it is, the person who's coming on receives a communication with instructions. So it would be very straightforward to add additional information if it was available for support around these types of things.
I'm gonna talk to Hang to talk to Amina to get that going in her role. And the Polk patients, just help me to understand, they're not all on one unit now. They're kind of scattered.
Right, they're on different floors, but cared for by a single group of residents and
Understood.
attending. Yeah.
Okay, got it. All right, I
And
will.
if you add yourself to the care team, because I generally know when any of my patients are admitted and discharged, if they're at Hopkins, because I have my name as part of the care team, so it pops up in my in basket, if there's been an admission or a discharge. So also making sure that you're added as the care team for, like, and for Moses and Patrice, I have the same thing for them as well as navigators, so.
Right. All right. Well, thank you so much, Sheila and Stephanie, for all these great updates, and we will continue to work on things and find more ways to do better for our patients.
Thank you so much.
Thank you so much.
All right. So just for the last few minutes, I don't